Let's ask the question, do diabetic patients living with diabetic foot ulcers fare better with amputation versus other interventions for preventing and treating diabetic foot ulcers when the patient is not included in the plan of care during the post-treatment or post-operative period? This PICO question is something that we are going to explore. An unfortunate outcome of diabetes is the possibility of foot ulcers, particularly in patients who already have a compromised immune system. Baig et al. 2022 note that, quote, for the treatment of diabetic foot ulcers, a multidisciplinary approach involving the use of diagnostic equipment, skills, and experience is required. Preventing amputations start with patient education, end quote. The case study provided looks at a 63-year-old diabetic patient who suffered from a left foot ulcer that became gangrenous with a resulting amputation of that left foot. 2 days following this successful surgery, this patient developed a fever with erythema and warmth noted to the stump tissues. The hospitalist recommended discharge. However, the surgeon believed an infection was developing and suggested that the patient remain hospitalized. After receiving antibiotic treatment for the infection and upon discharge to rehab a few days later, another team took over care of the patient. Education and therapy were the plan of care, to include a prosthesis with the anticipation that the patient would be compliant with those plans. However, it was noted that the patient struggled to stay with the plan, complaining of pain with movement and sneaking candy, despite counsel to maintain a proper diet. Referrals were made to a health psychologist in hopes that behavioral modification would improve the outcome for this patient. After a couple of weeks, improvement was noted, and the prosthesis was fit, and a lifestyle adjustment was apparently accepted. Slusser et al., 2018, pages 229 and 230. The interprofessional collaborative team included the following individuals. At the hospital, the team consisted of the hospitalist, the surgeon, and nurses. At the rehab facility, the team consisted of a physician, a physical therapist, an occupational therapist, a pharmacist, a nurse, and a social worker. The nurse and the physician were designated to take the lead in overseeing the general health of the patient. Later in his care, the team consisted of the patient, his family, an orthoticist, prosthetist, a pharmacist, a social worker, and a health psychologist. As the plan of care progressed, the outcome was not as positive for the patient as anticipated. A re-evaluation was done with the decision made between the team to postpone discharge and treat the patient with antibiotics in a hospital. A few days later, another reevaluation of the patient's progress was completed. Adjustments were made to the plan of care, and the patient was released to a rehab center where he improved somewhat physiologically, but lacking full patient cooperation with the plan. Recognizing that additional problems remained with the patient and the plan of care, the team reconvened and another plan was made. Soon, the team recognized the issues around the patient's inability to participate fully, to include the inability to fit a prosthesis, may be related to the patient's lack of inclusion with the plan of care. Thus, the team needed to reevaluate the plan put forth and revise it to include behavior modification provided through a psychologist in the hopes that the patient and his family would adapt to his new lifestyle and the physical and psychological demands that accompanied an amputation. This measure proved successful for the team and the patient and his family. Areas of improvement include identifying what the overall goal for the patient is with the patient's input during all collaborative discussion with the team. Family inclusion would also increase buy-in by them, as well as fostering their support to encourage the patient during difficult recovery phases. Incorporating a wound care specialist and an infection control specialist to assist with the healing of the surgical area brings additional expertise to the physiological issues faced by the patient. Group therapy that includes others with diabetes and/or amputation would be a strong means for the patient to feel less isolated in his disease process and bring support to the adoption of his new lifestyle. The patient would have friends in common, which is a powerful way to build a positive sense of belonging and attitude for behavior changes as needed. Spiritual leaders included in the discussion with the patient and the family would support the patient's belief system and bring hope during a difficult illness and recovery. Core competency VE4 speaks of unique cultures, values, roles, responsibilities, and expertise of others that impacts patient health outcomes. Subcompetency RR7 speaks of interdependent relationships with other professionals in and out of the healthcare setting with the goal of improving care and learning. Slusser et al., 2018, page 258. Utilizing these competencies in this case would prove a solid means to support the patient both inside the hospital setting as well as in the patient's postoperative future. Adopting these core competencies in any healthcare practice helps to ensure a positive outcome for patients. Thank you.